Welcome to this, our second installment in our 2020 Responsible AI series. My name is Jessica Wyndham and I direct the Scientific Responsibility, Human Rights and Law program at AAAS. We're pleased to host this series and thank Hitachi for their sponsorship. A review of Science magazine articles and other relevant literature of just the past 18 months reveals how we've been catapulted from a time in which AI was being heralded as a new frontier in detection, diagnosis, and treatment of disease as a potential tool for boosting efficiency and accuracy, to where the exigencies of the COVID-19 pandemic have now landed us, a time in which AI is core to the pandemic response, from efforts to trace contacts and track the spread of the disease to managing health resources. The focus of today's discussion is on AI as it's being used by hospitals across this country and presumably in many others to undertake triage. We'll talk about the technology and how it's being deployed. We'll discuss ethical issues raised by the use of AI for triage, and we'll talk about what we are learning now that should inform the post-pandemic use of the tool. To share with us their insights, I'm joined by Dr. David Magnus, Professor of Medicine and Biomedical Ethics at Stanford University, and by Dr. Karandeep Singh, Assistant Professor of Learning Health Sciences, Internal Medicine, Urology and Information at the University of Michigan, where he also serves on the Michigan Medicine Clinical Intelligence Committee, which focuses on implementation of machine learning models across the health system. The format of the discussion will be an interview with and conversation among our guests, with time for questions from our audience. So I invite you to post your questions throughout the discussion using the chat function on the right of your screen. Please include your name, and if you'd like, let us know where you're connecting from. So to get us started, I want to ask you, Dr. Magnus, can you explain briefly what is meant by triage and the context in which it's generally used?
Sure, and thanks for having me here. So triage as a concept was developed in the 1700s as the idea of sorting in accord with quality, but it came adopted in World War I for the sorting of wounded soldiers. And really, since then, it's really been all about the allocation of life-saving treatments where you don't have enough resources to really save everyone. Typically, the crude way of understanding triage is to divide into three groups, groups who are unlikely to benefit from treatment, those who can wait for treatment and don't need it immediately, and those who urgently require treatment in order to be able to live. And each of those ways of dividing things up correspond to different ways to different theories of justice, both utilitarian notions of trying to maximize good, as well as prioritarian notions of trying to benefit those who are least well off.
Thank you. Thank you for that pithy response. Dr. Singh, you conducted a study looking into the primary tool currently being used to conduct triage. Can you talk us through what you found and how we should understand those findings in the context of your methodology?
Sure. Yeah, so one of the things I would just say is that why do we even need triage? We need triage because we have a limited resource and we need to be able to risk stratify people into groups or into a spectrum of kind of risk so that we can take people who are on one end of the spectrum and give them access to a limited resource that we can't provide to everyone. So one of the ways in which we were struggling, or kind of one of the challenges we were facing as an institution back in March and April during the first wave of the pandemic, was that we had a limited capacity of ICU beds and we had a limited capacity of hospital beds. And thinking back to kind of what our internal projections were back in April for bed capacity, our hospital at the University of Michigan has 1,000 beds. And it was estimated that we would have somewhere between 3,000 and 6,000 inpatients if kind of exponential growth of our inpatient population kind of continued. So at the time that we had, I think, somewhere around 50 inpatients, this question really came up of how can we decide which patients can go to the ICU? And also, if we're going to open a field hospital because our hospital is going to fill up, how do we decide who can safely go to a field hospital? So in other words, we want to find people on the high end of the risk spectrum and people on the very low end of the risk spectrum, because we wouldn't want to send people to a field hospital who might need ICU level care, because we'd have to send them back to the main hospital to give them ICU care. So the study we conducted was essentially trying to validate a widely implemented but proprietary deterioration index to see if we could use it to risk stratify the patients hospitalized or a hospital with COVID-19 to determine, who out of those are likely going to need the ICU during their hospitalization, and who would not need the ICU after some degree of follow-up. And I think we chose 48 hours of follow-up, and thus could potentially safely go to a field hospital. We found that we were able to do this with a moderate degree of certainty. So if you look at the ability of this deterioration index model, and this was the EPIC deterioration index model to sort patients, the ability for us to do that fell into this kind of area where we felt if this is all we have, this is sufficient for us to use it. But our recommendation back to our clinicians was to use it in concert with other things like clinical judgment.
Wonderful. Thank you. Dr. Magnus, you touched on this a bit when you explained to us what triage means, but what are the ethical issues associated with triage in general? And how are you seeing those or new issues arising now in the context of the use of AI to manage triage during the pandemic?
Well, so in triage in general, you have very interesting trade-offs between these different competing theories of justice, and then especially the details of how you apply it. So, for example, a widely used tool for making decisions when you have shortages of ventilators and ICU level care is something called SOFA scores, sequential organ failure assessments, where you decide who the sickest patients are who need it but aren't so sick that they're unlikely to benefit. But it turns out, even in those very simple algorithms that don't really require AI, there are ways in which there can be bias built in. And that's in general one of the biggest issues around the uses of AI, is worrying that as we're making those decisions and using predictive analytics to stratify risk, that there may be biases against certain groups in the way it's done, biases against people with disabilities, biases against people who are poor, biases against people who are minorities. And that can happen in 4 different ways. First, you can have biases as a result of the algorithms that are being developed, and that can be either unintentional. For example, you use cost as a measure instead of health as your primary outcome measure. That was a very prominent example where, as a result of that, it led to systematic discrimination against African Americans. You can also have different ways in which specific interests are actually consciously and embedded in the algorithms as a decision. So a healthcare system could make decisions because what they care about is, in the end, financial stability, and that could wind up discriminating against individuals. There can also be bias as a result of the data itself. For example, if your data doesn't include adequate representations of certain populations, like minority populations, there will be an increase in variance and an increase in bias for being able to generalize to those populations in the application of the algorithms. There can also be ways in which there are biases embedded in the data because it, in the end, reflects biases of clinician practices. So if physicians don't list certain patients for treatment, or you treat African American patients differently than the same white patients who come in, if that's something that physicians do and that leads to differences in outcomes, that can sometimes be taught to the models and predictive analytic tools because they see those outcomes. For another example, if you never list, a lot of hospitals don't list for transplant kids with developmental delay. If you make those decisions, the algorithms will learn that those kids always die, but they're dying because of biased decisions being made by clinicians. And then lastly, there's inequality in our society. There's health wealth gradients, there's health disparities for different minority populations that wind up resulting in excess death in certain populations. And those aren't really a bias. Those are just a function of injustice. And of course, if you're going to learn from a society that's unjust in certain systemic ways in terms of the social determinants of health, then the algorithms will learn those things when it's primarily focused on outcomes for risk stratification.
David, that's a great point. And I think one thing I would add to it is a specific concern we had in our situation was that the model we were considering using and ultimately ended up actually using itself is a proprietary model for which the coefficients and kind of the underlying model structure and kind of the way it operates isn't public knowledge. And so I think when we were first kind of as a analytics team supporting our hospital command center operations, told that we had essentially 3 weeks until the field hospital was set to open, figure out how we're going to do this. We looked essentially at what's already implemented, and can we make sure that there are no obvious racial biases encoded within that, and biases based on other kind of characteristics such as age, such as sex, that were kind of evident. So we had to not only unpack those issues you're talking about. The second thing was we didn't train the model, so we had to actually essentially uncover the box and see, in the way it's actually performing in our setting, is it performing equally well in different settings? Is it giving you higher or lower risk scores amongst people of different racial groups? Recognizing that the disease, even in southeastern Michigan or in kind of Ann Arbor, which is a very predominantly white area, I think 50% of our hospitalized patients were Black, and so I think we were very cognizant of, is this model going to be problematic in ways we don't know? But in parallel, we launched efforts to basically log all of the scores so that we now have a variety of research groups on campus essentially developing kind of better versions of this score that we have a much better understanding of, because kind of they're developed in our patient population.
Thanks. I do think that's a really big challenge, because sometimes those things are hidden in ways that are not always apparent, at least initially. And I do appreciate that there are a lot of efforts to try and create fairer models, fairer algorithms. But even thinking about bias, that can mean such different things. So often developers are focused on whether or not you've got the data available to generalize, especially, you just gave a great example where you don't know what the training data even was. Will it generalize to your populations when those populations may be very different? And there can be technical notions of bias, but then you have to really see what the impact is, and that can often be important for uncovering other sources of bias, either in the design or that winds up being just a function of the way in which it learned from a biased society.
Thank you. And I think you're both getting to what I wanted to discuss now, which is about lessons that we're learning through the use of AI in this context. Can you dig a bit deeper? What are we learning now that is relevant to how we should continue to or not use this tool throughout the pandemic, but also once the pandemic is over?
So I think that's a great question. I think one thing we've learned is that no one hospital has the number of patients to accurately validate any AI model for COVID-19, because even though the impact of the disease is so global, it's so, roughly equally spread geographically. I mean, sure, there's hotspots, but it's so, pervasive across, the geography, that it just happens to be the case that no one hospital can really say, we've got the AI that can fix this. So, I think more than ever, in pediatrics, it's been appreciated for a long time that to study any kind of a disease, you've got to pool data across hospitals. You've got to pool modeling efforts across hospitals. And I think if you look at this, there's this scathing British Medical Journal systematic review of COVID-19, essentially AI tools, that says pretty much nothing out there is at a quality that should be used. And part of the reason for that is that everyone is competing with each other trying to build these things, rather than pooling resources to kind of build something that performs well across settings. So I think this is changing the paradigm a little bit in adult medicine, where very much the culture has been, pool only what you need to, but the more we can band together, combine data, combine modeling efforts, I think we'll have things that are sustainable, that actually perform well and continue to perform well, and not things that, perform well in the patients I looked at, but won't perform well next week, won't perform well in other settings. And that's kind of where we are, is that we've got these variety of things that overlap in function and goal, but none built on enough patients where we actually expect it to perform well and generalize.
Yeah, I completely agree. I know my colleagues' efforts to try and build better models for us for predictive tools for allocation in case we really did have to get to the point where we were going to allocate ventilators and things like that. And the numbers just weren't big enough. And then it raises challenging issues. We have a lot more ARDS patients, so patients with acute respiratory distress syndrome, than we have COVID patients, and over a much longer period of time. But will the experience with ARDS really generalize to COVID? And the answer seems to be sometimes yes, sometimes no. In some ways, yes, in some ways, no. And that winds up making it, I think you're right, the lack of sharing of that data across the country makes it very hard for AI. And then there's also just the practicalities. There's academic medical centers, but this, COVID is hitting people who are in community hospitals and small rural hospitals who don't necessarily have the same resources. So there often winds up being a default to very simple tools like SOFA scores, which we know it has emerged are going to be systematically biased in certain ways against certain populations. And there's also, I will add one other wrinkle. There are also things which I don't think are biased. And I tried to, some of those health wealth gradients and health disparities are real. And there can other things that we have to make decisions about whether we want to be accurate, recognizing that it will discriminate against certain groups. For COVID, that's particularly true about age. So do you want your models and your risk stratification to really be very sensitive to age, since in fact it is a very significant predictor of outcomes for patients? So do you risk stratify taking that into account, knowing that it means that while you'll get the most bang for your buck from a utilitarian point of view, you'll do the best for the most people by allocating resources that takes age into account, but it will also lead to systematic discrimination against people based on age.
Yeah, and people were very creative, I think, research-wise. They looked, one of the things you mentioned is we don't have enough COVID patients, so let's look at other patient populations like influenza-associated ARDS, which may resemble, COVID ARDS. So I think transfer learning is kind of that area of AI. So sure, I think a lot of people did leverage that, and a lot of efforts, both here and elsewhere I'm aware of, actually rely on augmenting our population of COVID patients with populations that may be similar in some of their risk factors or presentation. So I just want to say that's a great point. One of the challenges I felt back in March when the wave was hitting was this. We had 300, at one point we had, I think, about 240 patients in our hospital with COVID-19. And yet, if I wanted to build a model to predict ICU care in the hospital for patients, I couldn't actually use 240 patients because they were still in the hospital. So we actually didn't know for sure whether those patients will or won't need the ICU. So I think a lot of the early papers coming out, published in big journals like JAMA, were widely criticized because even though they had large numbers of patients, the majority of patients were still in the hospital, so their outcome was actually not known. So not only do you need, a large patient volume, but you actually needed to know what was going to happen with those patients. So if you're modeling those outcomes, enough time has passed where those outcomes have either occurred or not occurred. So, I remember our research databases couldn't pull data fast enough. I mean, we were pulling data every single day because every day our sample size was almost doubling. That's kind of what it felt like when we were doing this research. Very different from not being in a pandemic.
And that goes to my next question. We're in the midst of the crisis still. Let's put ourselves 12, maybe 18 months from now to a place where hopefully we can breathe a little bit more deeply and reflect on what we've learned, and also recognize that we need to plan for the next public health crisis, whether it's a pandemic or something else. If you were asked to help frame a plan of action that was being addressed at research funders, at industry, at academia, where do you think we need to be putting the emphasis to learn from these lessons, but to ensure that the next time around we're better prepared and can do it better? Dr. Magnus, I'll start with you.
So that's a hard question to answer because I think different kinds of emergency crises will wind up leading to different ways of thinking about it. In this case, we have a pandemic, so our critical infrastructure, physical infrastructure, is not impacted by this crisis. However, if we had a massive earthquake or thinking about Hurricane Katrina and the shortages and the crises that hospitals face there, that can wind up being a very different situation. And if you don't have electricity and you don't have access to electronic health records, you need to have tools that are simpler. One of the advantages of SOFA, even though it's very biased, is that you don't need all the technology that you might need for these more sophisticated tools to be able to calculate a SOFA score. So I think it's important to think about basic principles for allocation and how those govern, recognizing that different kinds of crises will present different kinds of limitations on what kinds of data can be accumulated, as well as the problem that was just mentioned about the fact that, if you don't have experience yet, it turned out the length of stay for patients who did go to the ICU was much longer than the other kinds of examples of like flu patients who go to the ICU. So experience, we just needed time and experience to even be able to implement tools that would be more generalizable. So I think all of that says that what we really need to focus on are the broader principles for allocation that can then be refined in accordance with the particular situation, crisis that you wind up facing. And that's more or less what we did. Our crisis standard of care at Stanford, we first developed a version of it between 2005 and 2007, and we had to update it and make changes, and we recognized some challenges and limitations to it. But a lot of that framing and that framework still remains even going forward.
And so what would be core ethical, social principles that you think should guide such standards?
I think we should be thinking about the trade-offs between the three theory-derived principles of trying to do the most good we can and really benefit the most people, make sure we're attentive to the people who are at the bottom and who are worst off and most likely to be discriminated against in the current system. And then within those things, we should allocate in a fair or equal manner. So you want to make sure that you don't have unintended ways of biasing, like first come, first serve, that you should, if you really have a tie, essentially, you should use a lottery system instead. So I think those are the sort of broader principles that you should really be applying in these kinds of cases.
Okay, thank you. And Dr. Singh, the same question to you. About 12 to 18 months from now, what would be your hope for the direction that researchers, industry, academia would be taking in this area?
Yeah, so I think I'll reflect back on one thing and then I'll answer your question. The thing I want to reflect back on is that, a lot of these models that we've got are really about risk stratifying because we've got shortages. And think about how many of the decisions during this pandemic have been driven by shortages. So originally the advice was don't wear a mask to the lay population because we don't have enough masks for healthcare providers. It was don't get a test unless you have symptoms in direct contact because we don't have enough tests to go around. We don't have enough ICU beds, and we don't have enough hospital beds, so wear a mask because now we've got the masks, but we don't have hospital beds. So I think one thing is go up as far upstream as you can and try to stop the problem there. And I think that's why simple public health measures like wearing a mask, social distancing, are things that are so critically important because those are things that can solve the problem as upstream as possible when it's possible to do it. In terms of what I think we should worry about in the coming months, let's say that we have a set of great risk models that we're able to build in the coming months that now help hospitals, providers, patients make better decisions around care around COVID-19. A question I would have is, today, if we had to flip a switch and distribute those algorithms to every hospital in the country, how would we actually do that? We actually don't have the infrastructure to do that. And so I think just like there's been a revolution focused on interoperability of healthcare data, I think right now we're in the midst of maybe the beginning still of a revolution to be able to interoperably share knowledge and tools and AI algorithms in ways that can be disseminated. So I think dissemination of these technical artifacts is going to be really something that I think we need to focus on, whether it's industry, whether it is hospitals, because the best algorithms can't save us if we can't turn them on.
Can I just add one other issue to this, which is we've been really talking primarily about triage in the context of crisis standards of care and allocation of resources in these emergencies. I do think it's important to remember that shortages and a lack of resources are ubiquitous in medicine in other contexts, right? No matter what, we for a long time to come are not going to have enough organs to go around, and so we have to use similar kinds of principles, which are in fact developed in our systems for how we allocate organs. There are drug shortages that occur on a regular basis, and we have to make decisions about how we're going to allocate those. So scarce resources are a ubiquitous feature of medicine. I completely agree with the point that as much as possible, we should work upstream to try and avoid them. But to some extent, they're a built-in feature of things. Drug shortages don't have to be built in, but the organ shortages probably do. And so we should learn from all those experiences. That isn't new, the shortages of organs, and using these very basic framework of principles have been utilized in organ allocation for a long time. And so I think we can learn from the areas where we do that to create a better and more just way of doing it in these crisis situations.
Thank you. Well, we're coming towards the end of our discussion, so I wanted to give each of you the opportunity for a minute or so to either underscore something you've already said or address another relevant topic.
Well, I'll go first. I would say just two things, which is when it comes to the use of AI, I think it's important to remember two things, which is first, that in the end, AI and predictive analytics are still just based on observations. They're essentially large-scale observational studies. So even though it's a lot more data and seems a lot more sophisticated, they still have all the limitations that observational studies have. And then so we just have to recognize that. And then second point that I would make is that they, to some extent, algorithms and models that we use, because they're based on our actual experience and the biases in our behavior that we have, in a lot of ways, they're a mirror that really looks at the limitations of our own society.
Thank you. Dr. Singh.
Yeah, so a closing thought I would have is that although a lot of work has gone into validating these kinds of artificial intelligence, machine learning models in the setting of COVID-19, the real answer that we want, that we need to know the answer to is, do these models actually improve patient care when linked to interventions? That's a much harder question to answer. And that goes back to traditional designs of studies like randomized controlled trials that have to be done to answer these kinds of questions. I think, that's something that I think we need to turn our attention to. There's been some great work happening from investigators across the country in trying to not just look at algorithms, but algorithms apply to patients and how that actually affects outcomes. There have been a handful of successes, but a lot more failures than successes. So I think the kind of intersection of AI and implementation science, I think, is a very fruitful direction going forward.
Wonderful. Well, thank you very much. And with that, I have to wrap up our discussion with a thanks to our guests, Dr. David Magnus and Dr. Karandeep Singh, and also to Hitachi for sponsoring the event. To our audience, please join us December 10 for the final in this year's series. Coinciding with International Human Rights Day, we will explore the many and varied ways in which artificial intelligence is being used as a tool for human rights research and documentation. In the meantime, check out the series website for Science Magazine resources on all the topics that we've covered. Thank you all very much and stay well.